Carcinoma pancreas. It is second most common GI malignancy, overall unfavorable prognosis with 5-year survival only 23% when localized and only 2% when distant metastasis at diagnosis. It is rare before 45 years, mostly. Occurs after 50 years, is male predominant and common in blacks. Overall annual incidence is 11-15 cases per 100,000 of population. Risk factors for CA pancreas. 2 important risk factors are smoking and alcohol. Other risk factors are red processed meat, DM. GLP-1 analogs, polyposis syndromes, Lynch, PJS, hereditary pancreatic cancer syndrome, and chronic pancreatitis. Tumor genetics. Mutations in TP53, KRAS, SMAD4/DPC4 and CDH1 etc. Signs and symptoms. Jaundice appears first when CA head of pancreas. Pain is of low intensity, dull, vaguely localized in the upper abdomen, may radiate to back and increase with food intake, leading to fear of eating resulting in weight loss and cachexia. Other symptoms are nausea, anorexia, exocrine insufficiency, and steatorrhea. With weight loss, it may cause acute pancreatitis when main pancreatic duct is blocked. Also, it is an important cause of diabetes mellitus. Diagnosis. Ultrasound abdomen will show biliary dilatation and presence or absence of gallstones. CT scan with pancreatic protocol is investigation of choice for diagnosis of CA pancreas. This dual-phase CT shows enhancement of normal pancreatic parenchyma at 40 seconds while tumor remains unenhanced, while at 70 seconds it shows involvement of blood vessels and liver. Sensitivity is 86 to 97%. But it's 77% when tumor size less than 2 cm. ERCP only required when diagnosis is in doubt and other periampullary malignancies are suspected. Brush cytology and needle biopsy is taken during ERCP. EUS is useful in the diagnosis of small-size tumors, or to assess vascular involvement in diagnosed cases, or to take EUS-guided biopsy when CT fails to confirm diagnosis. Also, in cases where tumor is unresectable, EUS-guided biopsy is taken for tissue diagnosis before palliative chemotherapy. MRI is not needed in all cases. Alternative to CT scan, sensitivity is 79%. Diagnostic laparoscopy is done when tumor size is more than 2 cm in head, CA in body or tail, borderline tumors, CA 19-9 level more than 150 U/ml or low volume ascites positive. Tumor markers where most important is CA 19-9 with sensitivity of 86% and specificity of 87% with cutoff value of 37 U/milliliter. It has good prognostic value. Other no-specific tumor markers are CA 125, CEA, MUC1, 3, 4, CK8, 18, 19 especially in ductal CA. Other tests CBC, sugar, LFTs, RFTs, albumin, bone scan etc. AJCC staging of CA pancreas. Primary tumor. Tis carcinoma in situ. T1 tumor limited to pancreas and less than 2 cm. T2 tumor limited to pancreas but greater than 2 cm. T3 tumor extends beyond the pancreas but not celiac axis and SMA. T4 tumor involves celiac axis or superior mesenteric artery. Lymph nodes Mets. N0 no regional lymph nodes Mets. N1 regional lymph nodes Mets. Distant metastasis. M0 no distant metastasis. M1 distant metastasis. Stage 0 TIS, N0, M0. Stage A T1, N0, M0. Stage IB T2, N0, M0. Stage 2A T3, N0, M0. Stage 2B T1-3, N1, M0. Stage 3 T4, N1, M0. Stage 4 NET, NEN, M1. Criteria for unresectability. When distant mets to liver, peritoneum or other sites. Encasement of celiac axis or superior mesenteric artery. Occlusion of portal vein or superior mesenteric vein. Malignant ascites. This CT unresectability criteria has 100% accuracy. Management of CA pancreas. Stage 0 surgical resection and adjuvant chemotherapy. Stage IA surgical resection and adjuvant chemotherapy. Stage IB surgical resection and adjuvant chemotherapy. Stage 2A neoadjuvant chemotherapy. Surgical resection. Adjuvant therapy. Stage 2B neoadjuvant chemotherapy. Surgical resection. Adjuvant therapy. Stage 3 palliative care. Stage 4 palliative care. Neoadjuvant chemotherapy is gemcitabine or 5-FU-based chemoradiotherapy followed by gemcitabine. Palliative chemotherapy is given in the form of only gemcitabine when performance status is poor. Alternative regimens are FOLFIRINOX or gemcitabine with paclitaxel. Novel drugs of CA pancreas are gefitinib, erlotinib, tipifarnib, miramestat, cetuximab, trastuzumab. Get MCT. Palliative measures are passing pancreatic SEMS, celiac plexus block/neurolysis, pancreatic enzymes. Nutritional support and treating diabetes.